Good afternoon, ladies and gentlemen. My name is Ritika Sharan, and I am a research intern at the Institute of Chinese Studies. It is with great pleasure that I extend a warm and humble welcome to another edition of ICS's Wednesday seminar titled The Rise of For Profit Medical Care in China, the Case of United Family Healthcare. After the collapse of the commune system, the state stopped funding the public healthcare and prevention services. People moved to the first-tier cities for better healthcare, leading to overcrowded public hospitals and poor experience by the patients. Slowly, this led to emergence of private hospitals. In 1997, United Family Healthcare opened its first international standard private hospital in Beijing. The company faced a series of hurdles to establish itself. Today, the United Family brand offers a chain of rehab hospitals, their own insurance platform, and home health services. The healthcare landscape in China is marked by a significant disparity between the ownership of hospitals and the services they provide. Despite over 60% of hospitals being privately owned, these facilities only account for 25% of inpatient services and 15% of outpatient services. This imbalance can be attributed to several factors, including the heavy subsidies that public facilities receive and the high corporate income tax imposed on private hospitals. The speaker for today's session is Ms. Roberta Lipson, who is the Vice Chair of New Frontier Health, Vice Chair of AmCham-China, Director of the U.S China Business Council, and the founder and CEO of United Family Healthcare. She also founded the United Foundation for China's Health, which focuses on providing life saving interventions for underserved populations with programs in cervical cancer prevention and treatment to rural women. She is an influential leader with over 40 years of experience and contributions that have earned her recognition, including the highest honor in Beijing to foreign experts, that is, the prestigious Great Wall Friendship Award and the China Pioneer Award. In 2015, she was named among the top 10 business leader of China. We are pleased to have you here, Ms. Lipson. The chair for today's seminar is Professor Rama V. Baru. She is a former professor at the Center of Social Medicine and Community Health in Jawaharlal Nehru University, Delhi. She is an honorary fellow at ICS, a member of the Ethics Committee at the All India Institute of Medical Sciences, and an honorary professor at the India Studies Center, Central China Normal University, Wuhan, China. Her major areas of research interest include the commercialization of health services, comparative health systems, and health inequalities. Her most recent publications include Commercialization of Medical Care in China, Changing Landscapes. We extend our gratitude to you for joining us today. Before I hand over to the chair, I would like to ask all participants to follow a few housekeeping rules. All participants are requested to remain muted during the seminar. You may post your questions in the chat box along with your name and affiliation. Alternatively, you may use the raise your hand option during the interactive session. After the presentation, you will be called upon to unmute yourself and ask questions. Over to you, Professor Baru.
Good afternoon. It's an honor and a privilege that I'm chairing a talk by Roberta Lipson. Roberta, I knew of your work while we were writing this book on commercialization of medical care in China with my co-author Madhurima Nande. And we chanced upon this very interesting history of entry of private capital into the Chinese medical care market, which actually began with the setting up of Chindex, which is the medical technology into China. And I don't want to get into great detail about it, but I can only tell you that both of us archived your interviews. We archived both your interviews to CCTV, as well as several journals and magazines that carried your interviews. And I think it's a fascinating story for China watchers like us, because we know quite a bit about the Indian market and the growth of the private sector in India. But I think it's particularly interesting to see how the private market grew in China and the kind of hurdles you faced when you brought this in the late 70s into China, which was always been associated with a socialist paradigm. And I think the reforms of the late 70s opened markets for China. And for a lot of us who are present today, we are looking forward to hearing this journey of the growth of the United Family Hospital and its expansion. With these few words, I hand it over to you now, and we look forward to your presentation. Thank you.
Thank you so much, Professor Barrow. It's really a pleasure to be joining you today from Beijing. And I'm glad to start the presentation. So assuming everybody can see my screen, I'll go ahead. So I'd like to start with a little bit of history. Sorry, I'm sorry, I'm having, do you have the mouse now? I'm so sorry, I lost power on my mouse, so. I have to ask for your indulgence for one moment. Okay, no, it's not working and I can't change anything. My keyboard is not working and my mouse is not working. I have a solution. Okay, my sincere apologies. We should be just fine now. Yes, no, the presentation is not moving. Okay, now it's moving. All right, so I'd like to start with sharing a bit of history of the public health situation in China. You know, when China first declared its independence, there was a real problem with life expectancy, with infant mortality, with maternal mortality, and as a result of I'm having a technological, so, okay. As a result of great ability to distribute healthcare through the commune system, they were able to really increase life expectancy as well as decrease infant mortality by a factor of 10 and maternal mortality by a factor of 10, while they increased life expectancy for the mass population. So they were able to do this partially because there was an increase in the GDP, and things really improved for many years until the 80s, when the distribution of healthcare spending stopped at the provincial capitals, and the commune system was basically disbanded. And so healthcare really couldn't get down to the grassroots. And as China pulled back from its public support of grassroots spending, the needs of healthcare really grow. So I'm really sorry that this presentation doesn't appear to be showing well, but it doesn't matter. So we'll start from the early stage of healthcare reform. It started with the government really pulling back from the original distribution system and investing in hospitals in the cities. But then they kind of let those hospitals start fending for themselves, and service began to break down. the service started to break down, and the slow investment of the government in the city hospitals, combined with the increasing crowding of those hospitals, bred tremendous dissatisfaction on the part of the public. And that dissatisfaction grew and grew until 2003 with the SARS epidemic. And the SARS epidemic kind of brought that dissatisfaction home to almost every Chinese person. They realized that if healthcare wasn't going to serve them well, they needed to know that in advance. And so they started complaining to the government, and they complained that they couldn't get access to healthcare, that healthcare was too expensive. And the government said, it's the fault of the hospitals, it's not our fault. And the doctors said, it's not our fault, you're underinvesting in healthcare. So things really looked like a crisis. And in fact, it wasn't so much that that healthcare was expensive, but it was more the fact that the government was only shouldering less than a third of the costs at the time. And so finally, in 2005, there was a declaration right post-SARS that in fact the healthcare reforms of the government was a failure, that there was insufficient investment, uneven investment, more investment going to urban than rural, where most of the people in the country were living in the countryside, so there was insufficient access. The drug distribution system was tremendously chaotic, and there were irrational economies where doctors were relying on kickbacks from drug sales to supplement the income that the government was paying them. So there was the start of the very famous Chinese corruption in healthcare. The government, to its credit, went out for proposals to academia, to think tanks, to consulting companies, to ask them, how can we solve this problem? And it took from 2005 to 2009 to settle on a plan. And that plan included increased investment, more even investment, improvement of primary care facilities, more equitable asset, and a pilot reform of state-run hospitals. So that was a great plan. Not only that, they backed it up with a commitment for spending of 850 billion RMB over a that's about 150 million US dollars, billion US dollars over a 3-year period. And as a result, over 1.3 billion people became covered by the public health insurance plan. They built many new hospitals. They increased spending on public health services, and all of that really brought a lot of benefit to people. But we can see that the coverage of the national health care plan, of the insurance coverage, although it covered 95% of the people in China by 2021, they were still really only covering a third of the needs. So in 2016, Xi Jinping announced the 13th five-year plan, which included a huge program for healthcare reform called Healthcare 2030. And that plan included lots of great stuff, including a commitment to spend 16 trillion renminbi, or 2.5 trillion US dollars on healthcare over that period. So not only did they make the commitment to the spend, but they also set up KPIs. How much were they going to increase life expectancy from 76 years in 2015 to 79 years by 2030? How much were they going to reduce maternal and infant mortality etc. So this, I think, is really a very enlightened approach where the government actually sets up KPIs for themselves. During this time, the number of hospitals grew exponentially because a lot of that investment was going to hospitals. But at the same time, the number of patients began to grow as well. More people had public insurance coverage. So what ended up happening is the more beds that were built, the more people were seeking care. And so even though it doesn't look so terrible that the occupancy rates are somewhere around 80-something%, actually the people were all flocking to tier 3 hospitals. So you can see that only 9% of the hospitals are considered class 3. That's the highest level of hospitals in China. But they were seeing 49% of the patients. And so you can only imagine how overwhelmed, overcrowded, and where the gaps in services may have been for those hospitals. Also, because of the increased coverage and the increased demand for healthcare, we start seeing the public healthcare account, the public social healthcare account, running at a deficit starting in basically in 2025. So we can see that if the demand keeps up at this rate, and if coverage doesn't change, and if the hospitals don't start improving their efficiency and cost basis, the public health system will eventually be depleted. So we can see that that has spurred a market in commercial health insurance, and we could see a great growth in commercial insurance right up until 2021. 2022, perhaps as a result of COVID and as a result to some of the policies having been too aggressive and were not able to continue the coverage at the rate that they thought they could build market share at. So the growth, the actual growth in policy revenues started to slow down last year. But that having been said, we believe that that growth will continue, that there's a huge need going forward for private health insurance. So now I'd like to talk a little bit about the development of private healthcare in China. So when I first arrived in 1979, there was really almost no concept of private healthcare. Through the 80s, through the 70s and into the 80s, there began to be small practitioners of private healthcare. The place that these practitioners came from is an amazingly interesting story in itself. Actually, it came from a gang of outlaws who were hiding in Inner Mongolia in the grasslands. And they discovered that the local people had a cure for skin rashes. And as a result, this cure, it was using some kind of lime preparation. They started packaging it and selling it. And because dermatology and venereal disease are both seen in the same department in China, they slowly, in addition to seeing people with skin rashes, began to treat venereal diseases. And this gang, which came from a Fujian province, from a specific city called Putian, started as venereal disease clinics. They built into women's hospitals, and then they started opening men's sexual function hospitals, and soon grew to be quite a very big business. But because the people that sought care there were there not because of superior care, but because of a desire to have more privacy than they could get at the public hospital, they were not really incentivized to grow in a really professional way. And as such, they sullied the reputation of private healthcare right from the beginning. So people, when I got to China in 1979, clearly thought that private healthcare was inferior, and they always would go to the public system if they had the choice. Sometimes the private system would attract patients by charging very, very low prices, but the reputation continued to be quite poor. When I got to China in 1979, I discovered that one of the big things that was missing from the public health, from the public hospitals, was modern technology and modern equipment. So our company began importing modern medical equipment and distributing it throughout China. We grew our company for 10 years and ended up with quite a substantial national distribution business in the area of medical equipment. After 10 years, it became apparent to me that what was missing around the delivery of healthcare in the private system was not just hardware, but the whole philosophy surrounding patient care, surrounding patient services, surrounding quality. And we got the idea that there was a growing international population in Beijing. They were leaving China at every opportunity if they ever got sick, even small sicknesses, because they weren't comfortable with the healthcare that was available. At the same time, we were watching Chinese officials from the Ministry of Health, from hospital leadership, going to the United States, looking at the best hospitals in the US and saying, wow, this is great, that's great, but we could never implement it in China, including they would walk into a lobby and say, wow, it doesn't even smell like a hospital. And they said that couldn't possibly happen in China. I believed it could happen. And so in 1992, we started talking to the government about allowing us to open a small hospital which could service the international community and help them in their quest to attract more foreign investment, because multinationals will not invest in a place that they don't feel there's sufficient healthcare for their staff. So it took us 4 years to convince the government to allow us to do it, and then another 3 years to build. So from like 1991 to 1997, we prepared to open our first small hospital in Beijing. To open the first hospital, we needed to get approvals and chops from over 180 different offices of the Chinese government. It hasn't gotten much simpler now. Healthcare, of course, is heavily regulated in every country, and there's a good reason for that. But it's still especially difficult for a foreign invested healthcare provider to open a facility in China. So after we opened, we were not solely treating venereal diseases, and we were not charging the lowest price to patients. We decided what we wanted to do was bring international quality and the highest level of service to patients. And so starting in the 90s, really, the government slowly began to see that there might be a benefit to sharing the burden of healthcare with private industry. It started slowly. We, I think, could be credited with helping to build a more positive reputation for private healthcare in China. And by the 2000s, the government started rolling out policies supportive of private investment in healthcare. And we can see that, very interestingly, if we look back to 2009, only 36% of the healthcare facilities in China were private. But when we got to 2020, the ratio flipped, and 66% of the facilities were now private. That having been said, even until now, less than 20% of the outpatients and around 20% of inpatient care delivery are delivered in the private facilities. That's partly because some of the successful private facilities are charging higher prices, and partly because it's impossible for a private investor to build hospitals on the scale of the public hospitals in China, in which 1,000 beds is considered small, 5,000 beds is considered kind of large, and it goes up from there. So we can say that there were some successful startups. Following our success, there were other specialty hospitals and even one general hospital, which is Jiahui, that made investments deciding to take the high road, to deliver excellent service and charge a market-driven price. So some of those investments have been successful. And in fact, there was a huge boom in investment in private healthcare all the way through 2020. But COVID struck a really disastrous blow to many of the smaller investors and even many of the large investors who came from the real estate sector, who came from other sectors, even the food and beverage sector, who wanted to diversify into healthcare, but really did not have a very clear concept of their strategy or what they could bring to the field. So the number of private facilities grew exponentially, but the number of private facilities that really were successful were quite limited. In fact, since COVID, we've seen over 2,000 private healthcare facilities declaring bankruptcy. And even in the first quarter of this year, we've seen many other failures. That having been said, there is a huge potential for healthcare in China. The reasons include the rapidly aging population. This is a problem for China and many other countries in the world, and is going to increase both the burden and the demand for healthcare over the next 10 years. Secondly, the increased burden of chronic diseases, which needs to be dealt with. Thirdly, the increased burden of cancer and the disproportionate level of mortality of cancers in China compared to the West. So even the healthcare spend, the government has committed to 16 billion renminbi spend by the year 2030. So definitely there's a growing need. There are different models of private healthcare in China, doctors groups, some kind of retail medical malls that have been popping up, internet hospitals, specialty hospitals, and I'm proud to say United Family, which is truly an integrated healthcare platform covering the full life cycle of healthcare and covering a good portion of the geography of the East Coast of China and the full life cycle of patient needs. So as I mentioned, our business started in 1979. I proudly hand carried the first ultrasound machine into China. We brought many of the other firsts, including patient monitors, including ultrasonic scalpels, electrosurgical generators, first MRI, and the first surgical robots. So that was Chindex, which grew from 1981 to 1994 as a private company. In 1994, we did an IPO on NASDAQ Stock Exchange for the purposes of building our first hospital, which opened in 1997. It was a teeny hospital, less than 50 beds, servicing mostly expatriates. 99% of our patients came from outside, well, were residents of China, but came from outside of China. Today in 2024, we have 11 hospitals and 25 clinics. We have over 1,500 medical professionals. We're serving patients from more than 173 countries, but now almost 90% of our patients are Chinese citizens. So not that the number of expatriate patients have gone down, but more and more Chinese patients have the economic wherewithal, they can afford to access our services, and they're willing to access our services. So our hospitals are in 3 clusters, one in the north, one in the east, and one in the south. We have in each one of these clusters both acute care hospitals, primary outpatient care clinics. In some places we have rehabilitation hospitals, and we have home health. So those are our 3 clusters. And we're proud that in every one of our clusters, we deliver services from prevention to diagnosis, to treatment, to rehabilitation, as well as home health in an integrated environment. We also have an internet hospital, and our license allows us to service patients from the whole country, whether we have physical hospitals in those locations or not. And we have 1 permanent electronic medical record, which means the patient from cradle to grave, if you will, has the same medical record following them. Also, a patient that enters our system in Beijing, maybe his family moves to Guangzhou, he goes on a business trip to Shanghai. It doesn't matter where, his medical record will always be with him. We also started about 10 years ago working with insurance companies on a shared risk model where we get paid on a capitated basis and take care of our patients from prevention through care. We also have an increasing academic bent where we have international academic exchanges. We're able to live stream these exchanges and including live stream surgery. And sometimes millions of viewers tune in. Chinese patients are very interested in healthcare. We cooperate with many, many insurance providers. We have direct billing for our patients. And in 2019, so I mentioned that we had an IPO on NASDAQ in 1994. We then privatized in 2016. Our public shares were bought by a consortium of TPG, which is an American private equity company, the Fosun Group, which is a major Chinese conglomerate, and myself. So we became a private company, and when it became time for our private equity's exit, we decided to merge with a SPAC on the New York Stock Exchange called New Frontier Health. Since then, we have again privatized, but together with New Frontier Health, we have an expanded ecosystem of healthcare. And that includes, of course, our United Family brand, which is the number one private healthcare brand in China. But we also have a chain of rehabilitation hospitals. They have, it's called Wulian or Care Alliance, and they have 20 rehabilitation hospitals in second-tier cities, second and third-tier cities in China. We have a home health care network called YD Care, which sees tens of thousands of patients a day and is the second home health care company second largest home health care company in China. And we have created an insurance platform and insurance distribution platform called Better Health and Prosper. So through this ecosystem, we're really able to service many, many patients in China. And in fact, we believe that the future is bright. We've opened 3 new hospitals over the period of COVID. We have plans to open a major academic integrated clinical and research medical center in Beijing, and continue to grow our education and training offerings, as well as our insurance offerings. Now we see 12.4 million outpatient visits in our home care network. We have 1.9 million inpatient days. We operate in 77 cities. We have 10,000 employees, and we're doing pretty well on safety and quality. So that's the story of United Family Healthcare. It's the story of the growth of private health in China, and I'm very glad to answer any questions that you might have.
Thank you for that excellent talk, and I think we can open the floor for questions. Okay, I think while others may be mulling over what to ask Roberta, I think, Roberta, this story is a particularly interesting one because it's a very old U.S. China relationship, which has been built up over the years, and also a changing scenario of the economic landscape of China. And I think what was particularly interesting in this presentation was, while the number of private hospitals have grown, the number of patients actually is still very heavily reliant on the public system. So it also shows you this a very heavily invested public system with very large hospitals, and also a private sector that is sort of growing and addressing some of the needs. So one of the questions I had was that, is it the case that some of the private hospitals offer much more general services than they do specialized services? And what is the human resource story in this? How many doctors really are willing to get employed in the private sector?
Well, that's a really great question. So some of the more successful investment stories in private healthcare have actually been specialty hospitals. So I think the most famous one is the Eye Hospital. And there are very few private hospitals that are really offering comprehensive general care like United Family. There's a hospital in Shanghai called Jiahui, which is, there's a private hospital in Nanjing, which is, but there aren't very many. There are more stories of women's hospitals, which grew out of that Putian group that I talked about earlier. And there are more eye hospitals, some orthopedic hospitals, very few general hospitals. For us, one of the biggest challenges at the beginning was getting professionals, getting doctors and nurses to give up their iron rice bowl and move over to the private sector. We were only a small experiment, and we wanted to attract the best doctors in China, and that was very, very challenging at the time. We also wanted to bring doctors from the United States and Europe, and China was an unknown quantity to them, so it was extremely challenging. But as our reputation grew, we became a kind of preferred employer. First of all, I mentioned the issue of the need for doctors at a certain point to supplement their income from the state with perhaps kickbacks, if you will, from drug prescribing or from device companies. And increasingly, doctors felt uncomfortable with this, but if they came to work in our system, they didn't need to do that because they were paid a living market wage. And so that became an attraction for many doctors. Also, the working environment was an attraction for many doctors. Of course, they needed to see far fewer patients each day than they needed to in the public system, and they had the luxury of being able to give patients their due and spend 15 or 20 minutes in the outpatient setting with a patient, which would be impossible to do in the public system. So slowly but surely, we became a preferred place of employment. And most recently, the government has also started to introduce DRGs in the public system. And they've started to restrict doctors to what sort of drugs that they could prescribe and what sort of implantables they can use. So they limited doctors in the public system to a certain formulary. And some doctors who wanted to do more innovative work were interested in going to the private system where they might be able to use things that weren't on the public formulary. So that became another attraction. And the anti-corruption campaign in the public system also further, I think, pushed doctors to consider, would they like to go somewhere where they can earn a fair wage without having to take money that really shouldn't be taken.
I see a hand up. Would you like to ask a question, Madhurima?
Yeah, hi. Good afternoon, Ms. Lipson. It's great to meet you online. And I must say that it's been a decade since we started our work on China and did our first visit to Shanghai and Beijing. And I remember in 2014, we were actually looking to interview you, but couldn't get through to you because I think there was this big merger having with Fosun at that time. So since then, we have been kind of seeing the journey that United Family Healthcare has made over the years. My question is specifically about the public-private partnerships that are happening in China. We had been looking at it some time back as to what kind of partnerships are being built between the public sector and the private healthcare or private financing for that matter. How do you see that has come along in China, and what role does United Family Healthcare also play in these partnerships? Thank you.
So that's a really interesting question because it has been a rocky road. The regulatory environment for public-private partnerships has been somewhat schizophrenic, I think. On the one hand, the government is very welcoming and wants more private investment. On the other hand, they worry about how the public and private facilities would play with each other. And so there's a limitation. For example, public hospitals that accept the public insurance reimbursement are only allowed to allocate 10% of their beds for non-public use, for charging higher prices, for example. And even in that case, even when there's no foreign investment in that situation, there's a big question about how does the sort of high-end private part of the hospital play with the rest of the hospital. And so, yeah, so it's quite complicated. And for a public hospital to invest either their assets or their capital in a private for-profit facility, at this point in time, it's not legal. It's not allowed. And hospitals that did that in the past have had to either close that facility or figure out a way to get out of it. Because it was considered kind of using private funds. Now, the government does from time to time buy services from private healthcare. And so that is one kind of public-private partnership. And I must say during the COVID outbreak, responding to the epidemic really, I don't think ever differentiated public and private. So we all tried to work together. But I could say that the regulatory environment for public-private partnerships right now in China is not very clear and is not very fertile ground. It seems to work out better when private plays with private and public plays with public.
Any other questions?
Thank you. Yeah.
Can somebody from ICS please read Purnima's question?
Yes, ma'am. Ms. Lipson, there's a question in the chat box. It's from Purnima Nair. She's a research intern at ICS. She asks, could you please highlight the role played by the private hospitals with particular reference to COVID? You mentioned that the share of private hospitals went up by 2020. So was there a preference for private or public hospitals considering that the healthcare system was at its limits?
Right. So our experience in COVID was extremely interesting, and I can also contrast it with our experience during the SARS epidemic. I have to say that through the after the problem was recognized, for a while it was kind of hidden in Wuhan, and we didn't know what was going on. But as soon as by February, when China it came out with the whole story, or with most of the story, we felt that the public health authorities were really on top of things, that they gave us really good guidance. During SARS, not so much. I think that China was completely unprepared for the SARS epidemic, and but they were very open to foreign and international input. The WHO was in from the beginning during the SARS epidemic, and the Chinese Public Health Authority was very open to their input. During COVID, though, it seemed that the Chinese Public Health Authority was very on top of the situation, less willing to accept interaction from foreign health authorities or even the WHO. But we felt we were getting very good guidance about how to stay on top of our infection control. For example, China was very strict. From the beginning, we had to separate our emergency room into fever clinic, pediatric fever clinic, and normal emergency room. Every few months, the requirements for fever clinics changed and got stricter and stricter. Somewhere halfway through the epidemic, every one of our hospitals had to purchase an extra CT machine, an extra CAT scanner to put in the fever clinics. But I think that the number of cases were kept pretty well under control. That having been said, still the public hospitals were quite overwhelmed. And rather than deal with the risk of infection, some of the hospitals actually public hospitals closed down many of their services. So not only did COVID patients find it hard to find care, but people that were in the middle of, for example, cancer treatment, or people that had other non-COVID related diseases, for example, a heart attack or a stroke, or even a non-COVID related pneumonia, had a problem to find places to get care. So during this time, we were able to care for many patients who may never have thought about private health care before. And because at this time, we were able to save their lives, they were so grateful. Many have become our loyal patients. So was there a preference for private or public hospitals? Well, during the epidemic, the preference was wherever you could be seen. And because we had a lot of access to international information, being an international organization ourselves, we were able to do some things and benefit not only from the public health authorities' advice, but also from the experience of the international community. For example, we had stocks in Paxlovid where the Chinese hospitals did not. So were people thrilled and happy to be able to have access to this very important therapy? Yes. And so those people that got to know about it and got to get care and got to have their life saved at our hospital really did shift somewhat the perceptions of private healthcare. So at the same time, I think the fact that people did not get so easy access to the public system shook their faith and their trust in the public system a little bit. That coupled with now this slow diminution of the reserves of the public insurance fund, also shaking people's confidence in the public system. So I have to say that that the interest of the public in private care is certainly growing. Are the hospitals both public and private bound to follow quality and cost control measures? Right, this is a second question. So yeah, so during COVID, I think there was a little bit shift in people's preferences, and the positive preferences really accrued to the private system. Yeah, I think it raised people's appreciation for certain private hospitals. At the same time, because things were really tough during COVID, many private hospitals went out of business. So for some of us, it was really good. For some of us that were well prepared and had our infection control procedures in place, the growth during COVID was positive, net positive for us. For many hospitals who were not so prepared, they even went out of business during the COVID time. So next question.
Ben Hunter, would you like to?
Hi, can you hear me okay?
Yes.
Okay,
Yes.
thanks very much. I think Alka Acharya was actually in front of me, but I'm going to jump in anyway. So yeah, I'm Ben Hunter. I'm University of Glasgow, and really enjoyed that talk. Thank you very much. I thought it was interesting insights into the process that's unfolded over the past few decades, and your perspective and experience of doing that. I was interested in particular around your experiences working with private finance and kind of navigating those sorts of financial systems in terms of attracting investment, growing the company. I think it's, you know, for those of us who work in kind of healthcare sectors, it's quite an alien sector for us. So I suppose it'd be interesting to hear how you found that kind of process and experience over, I guess it's the past decade or more.
Well, more. So when we decided to open our first hospital as a distribution company, we did not have great reserves of capital to invest. And once we got the approval from the government to go forward, we needed to find financing. And there were no sources of financing in China. There was no public market. There was no possibility of debt or bonds. And so we went to the U.S. and I was really a babe in the woods because my whole career was here servicing the medical community. And but we did find a small investment bank that was willing to underwrite our ridiculously small IPO. We raised $10 million and were able to build our first hospital with it. So as I mentioned, it was very small. But being a public company then gave us access to secondary market, and we were able to raise funds and grow. And we were public until 2016, so almost 20 years. And then began our introduction to the world of private equity, which is a whole different story and a whole different set of lessons learned. Right. And then now, actually, our major investors are people that came from the finance world. So people from Blackstone that decided that they wanted to build the rest of their career in healthcare. So now my new partners from New Frontier Health come with a wealth of financial experience. And of course, that makes things much easier for us. Over the time, we raised money first from our IPO and then in the secondary market. And then we were able to get financing also from the International Finance Corporation, from DEG, both debt and equity. And it was good. We were able to get what we needed to grow. And I think we will continue, especially now with the expertise of our New Frontier partners, continue to be able to finance our growth.
Thank you.
Ravi, would you like to come in?
Sorry, can I come in? I had put up.
Thank
Yeah,
you.
sure. Alka, sorry.
Okay,
Okay.
all right. Thanks. Hi, Roberta, good to see you. So thank you so much for agreeing to come on this. As you can see, there's a lot of interest. I'm going to put this off because the voice is sort of going a bit. So just let me try and. So I really have a question of a larger nature, which I would like to draw upon your long years of dealing with the Chinese, and it kind of borders on occupies the region between politics and culture, because the first thing that interests me is that how did the Chinese respond so positively and actually offer the space for the inclusion of private services in an area which was traditionally seen as very, very strongly the state's domain. How and where do you see, and I mean, what I'm trying to say is that what were the factors which made them respond so positively? And it's not just obviously the reforms that are taking place. And two, do you see, these questions have come up ahead also, but slightly shift from the nature of the public and the private to ask that, do you see the state actually conceding more and more and more and eventually is moving in the direction of complete privatization? Because obviously it seems as if the private has been expanding. So just these two issues.
Right. Well, I don't think that the state's support of private healthcare was automatic at the beginning. In fact, not only were the consumers and patients suspicious of private healthcare, but the government was as well. And it took us a long time to convince the government to allow us to open our first facility. Over time, as more and more Chinese people prospered and had more money, the government started seeing people going abroad for care. And there was a question of desire to attract more foreign investment, and multinationals wouldn't come to a place where they weren't confident in the healthcare. So for us, early on, the way that we got approval from the government was to tell them that we would help improve the investment environment by making international standard healthcare available. At the same time as Chinese people became wealthier, they started going abroad for healthcare, and the government realized that they needed to keep that upper end of Chinese socioeconomic strata happy by providing them, not only allowing them to live in beautiful houses or carry Louis Vuitton bags, but also if their desire was to have better healthcare, there needed to be an outlet for that. And so I think the government realized that it was hard for them to use public money to build high service standard healthcare, and easier to see that that section of care to the private sector. As I mentioned, they found when they allowed public hospitals to devote 10% of their beds to higher end care, it doesn't go well in the public sector. So I think that's part of the reason. Now, as we see the public insurance fund being somewhat depleted with the extra needs of the aging society, with the extra burden of chronic disease and cancer, they realized that it would be great if people and commercial insurance would shoulder some of those expenses. And as such, to, I think, incentivize people to bother buying private insurance or, spending their own money, there needed to be a whole different level of care available to them. So, I think it's a practical decision on the part of the government. Yes, healthcare is emotional, even in a non-socialist society like the United States. Obviously, a lot of people considered healthcare an entitlement. In China, a lot of consumers considered it an entitlement. But I think after the experience of COVID and after the experience of many returnees from overseas having experienced other approaches to healthcare, the demand grew, and the government was happy to let someone else with investment respond to that demand.
Thanks. Rabi?
Dr. Lipson, that was a really enjoyable and fascinating talk. I want to ask you about the public health system in China. As we know, it started from the so-called barefoot doctors and so on. We've heard a lot about it. But as we just heard from Alka's question, the healthcare was right from the beginning deemed to be a public responsibility of the government. Now, in other cases where people have suffered very badly due to some form of mass infliction or affliction, like, for example, very bad air pollution or the adulterated drugs or milk scandals about 10 years ago, the public reacted very strongly. And therefore, the government took that seriously and took remedial action very fast. So what is it in the public healthcare sector that is holding the government back before really applying themselves to this task? Is it manpower? Is it just the money? And they must be very conscious about the depleting population. So what is holding them back?
Good question. I think that it's a combination of issues. As I said, this fear of depleting the reserves in the public social insurance account is something that's very, very concerning. I think that there's been a bottleneck in training sufficient numbers of highly trained doctors. They tried to, in that Healthy China 2030 plan, move as many patients out of the third-tier hospitals into the community clinics. And that was a disaster because they staffed the community clinics with under-trained doctors. They tried to turn specialist doctors into family medicine doctors after 3 weeks or 3 months of training. Whereas, as you know, in the US, I'm not sure of the Indian system, but after your bachelor's degree, you got 4 years of medical school, 1 year of internship, 3 years of specialty training in family medicine, and then maybe a fellowship. So to look at those quickly transformed specialists into primary care doctors, it didn't work. People weren't getting their problems solved at the community clinics. So everybody rushed back to the 3A hospitals, overwhelmed them again. And it's just not the way things should work. Acute care hospitals shouldn't be the ones treating coughs and colds, but that's what happens in China. So, and then the economics of it is very complex. You know, to pay doctors, they've raised the salary of doctors a little bit in the public system, but to pay them as much as they were earning through their under the table payments and kickbacks from drug companies, it would also bankrupt the public system more quickly. Probably not possible. So I'm not sure what the solution is, but I think in the face of that, seeding some of the more expensive care and, if you will, optional luxury care to the private sector makes sense for the government.
Thank you. Thank you.
Pallavi?
Yeah, thank you. Thank you, Dr. Lipson, for that great talk. So I work in India, and so my question is also coming from the context where I'm in. And we have a slightly different situation. While there are similarities also, we have people flocking the tertiary sector, bypassing the primary and secondary, which overburdens the tertiary sector, similar to what you mentioned. But we have the other way around, where a large portion of the population seeks care in the private sector, and a lot of expenditure is out of pocket. There is no universal insurance as such. So my question is related to that aspect. So are there, I'm sure there are regulations, and you mentioned you had to take some monetary clearances to start your hospital, but your hospital and even some smaller private hospitals, how are they regulated in terms of quality and cost, and also public hospitals for quality, and who monitors them? Because in India, that's a very, very gray area and a very weak area, because of which people really don't know how to manage, and there is a whole lot of out-of-pocket expenditure. And do people have any role in such monitoring? That is my first question. And second is regarding distribution of private healthcare facilities. Is there a mechanism by which it is decided that private providers can open facilities up to a certain population, not more than a certain number of facilities per certain geography or certain population, so that it's not that they're concentrated in one area and some areas are left out? Is there any sort of control on how the facilities are distributed? Thank you.
Yeah, so interestingly, when we opened our first hospital, the Chinese accreditation system was very much an asset-based accreditation system. And still to this day, it is mostly an asset-based system. So the Chinese public hospitals are separated into tier 1, tier 2, tier 3, with tier 3 being the highest. And the most clear-cut requirement is how many beds do you have? So if you're a general hospital, you have to have 500 beds. If you don't have 500 beds, you can't be tier 3. And a lot of the approvals for providing certain services, for example, you can't provide IVF services if you're not a tier 3 hospital. You can't do certain kinds of neurosurgery or robotic surgery or open heart surgery. So it's as far as I'm concerned, an irrational requirement, because especially as more and more care is done on an outpatient basis, especially as more and more surgeries are minimally invasive. So there's not that need for so many beds as in the public system. And in fact, the huge size of the public hospitals, as far as I'm concerned, is an irrational economy. some of the way the reimbursement in the public system happens also is really strange, because certain kinds of interventions can only be reimbursed on an inpatient basis, which is not good for the patient, not good for the hospital, and not good for the government's pocketbook. But that's what the rules are. So there's this asset-based accreditation system. Does it really, you have to have how many pieces of equipment, how many beds, how many doctors, how many nurses. That's one way that the government oversees quality. There are frequent inspections by the government to make sure that you're still meeting the standard that they allowed you to set up with. Patient complaints to the government cause points against a hospital, and infractions on standards also will earn a hospital negative points. And with a certain number of points, you get kicked off the public insurance reimbursement scheme, and with a certain number of points, you will be closed down. So it's a kind of cumbersome way of monitoring quality. From the beginning of United Family, we adhered to Joint Commission standards and accredited every one of our hospitals and clinics every 3 years. Sadly, Joint Commission left China last year, so we continue to do our own audits based on the Joint Commission standard. What does that mean? I think that China was a bit uncomfortable with public hospitals seeking accreditation from a foreign accreditation agency, and that caused Joint Commission's stay in China to be a bit uncomfortable. So the tier 1, tier 2, tier 3 proactive audits on the part of the government for existing hospitals has more or less stopped. Some new standards have been issued, but they still have this hard requirement for scale and bed numbers. The question about what allows for licensing, what allows hospital to be licensed, is there a problem with geographic concentrations? Some cities have requirements that hospitals or clinics are not allowed to open within a certain distance of each other. 10 years ago in Shanghai, that was a huge problem. That requirement seems to have gone away. And if a private investor can convince the government, the local government, of the need within that area, even if there is a hospital next door, they can get an approval. There's no hard and fast regulation for geographic distribution. The local government has to approve, and then depending on the size of the investment and the size of the hospital, so it might be the district hospital has to say, we have this need and we agree to it. Then it goes to the municipal government, then it goes to the provincial government if the scale is big enough of the investment.
Thank you. Are there any further questions?
No, Professor Baru.
So if there are no further questions, Roberta, this opens up a whole area of interest for those of us who are in comparative studies and China studies, and I hope that we will continue to learn from you, and we would love to sort of compare and contrast the Indian system of commercialization. But interestingly, one of our corporate hospitals was in conversation with a couple of Chinese private hospitals. But I don't quite know what happened to that. This is the Apollo Group. And why it didn't go further is an interesting question to ask. And also to see what kind of a role they would have in future, both in pharma and in the case of the hospital industry. Thank you very, very much. And it was indeed a pleasure. And I want to thank you on behalf of the Institute of Chinese Studies. Over to you for the final closing of the talk.
If he's thanking, then don't worry.
Yes, before we go, I'd like to thank you for the opportunity to speak with all of you. I have to apologize for the technical difficulties at the beginning of the presentation, but I hope it was okay once we got over it. And if any of you do choose to visit China, it's a really interesting place, great place for tourism. Or if you care to come on your academic inquiries, I'd be very happy to host you. So please do let me know.
Professor Baru, I seek your permission to formally bring an end to today's session.
Yes, please. Please go ahead.
With this, we come to the end of today's seminar. We thank Ms. Roberta Lipson and Professor Rama V. Baru for gracing today's seminar with their presence and for giving us their precious time. We also offer our gratitude to the audience. The video of today's seminar shall be available on the ICS's YouTube channel. We extend a warm invitation to all for the upcoming Wednesday seminar scheduled on 12 June 2024 at 3 p.m. IST. The title of the seminar is From Old to New, Tere Ghar Ke Samne and Fractious Neighborships in 1962. Details about the event can be found on the ICS website, or you can subscribe to our newsletters for regular updates. Thank you everyone for joining us today.
Thank you.